Hello, and thank you for joining us today. My name is Barbara Eichhorst. I'm a certified diabetes care and education specialist and a quality coordinator for ADA ERP. Today, we're going to talk about Standard 4 that addresses delivery and design of DSMES, Diabetes Self-Management Education and Support Services. We're going to talk about general guidelines for Standard 4, as well as provide you with example of how to integrate Standard 4 into your practice. Standard 4 involves delivery and design of DSMES services, which is a curriculum. And DSMES service will utilize a curriculum to guide evidence-based content and delivery to ensure consistency of teaching concepts, methods, and strategies within a team, and also to serve as a resource for the team. So it is your curriculum go-to, not just about the content, but also how you deliver your curriculum. Versus DSMES team will have a knowledge of all of the respective emerging evidence and advances in education strategies, pharmacotherapeutics, technology-enabled treatments, local and online peer support, also psychosocial resources, as well as delivery strategies relevant to the population that you serve. So what is a curriculum? A curriculum provides guidance for the DSMES team, effective teaching strategies, and methods for evaluating learning outcomes, and includes all aspects of diabetes self-management and support. So think of a curriculum as you guide on how you are teaching a person with diabetes, and not just how, but also making sure that that person is learning the information, because we can teach, but it doesn't mean that a person is learning and is able to apply that information. So curriculum has all of those aspects in place to ensure that you're providing effective education that produces better outcomes. So therefore, think of DSMES delivery that should integrate topics across content areas rather than just focusing on one item or working in silos of the content, as it will limit informed decision making. Also, the delivery of curriculum content must be dynamic and based on continuing assessment of need, preferences, and evaluation of outcomes. We know that there is various methods of delivery that can increase communication between a person with diabetes and the DSMES team and improve diabetes-related outcomes. These would include virtual, telehealth, telephone, text messaging, and web-based or cell phone applications such as apps. The most effective and evidence-based delivery methods move beyond the basic acquisition of knowledge, and they are to support informed decision-making while addressing psychosocial concern of the person with diabetes. A curriculum involves a use of interactive teaching styles that include meaningful discussions to address individual questions and needs while focusing on the culture of positivity within the DSMES services. So you really want to focus on that individual need and their own preferences and learning information that they can actually apply in real life. It's not about just knowing what to do with diabetes. It's being able to apply it to their daily routine and create healthy habits. So the curriculum content delivery should be creative, culturally appropriate, and adapted as a necessary for the individual and groups within the target population. And that cultural appropriateness is very relevant. It's not just enough to have an educator who speaks that language, but making sure that that clinician or educator is able to culturally have a cultural competencies that would allow to tailor the education to the needs of somebody from a different cultural background. Overall, it is recommended to include practical problem-solving and self-advocacy approaches, as well as a collaborative care, including family and peer support. addressing psychosocial issues, behavior change, diabetes devices, and strategies to sustain self-management efforts. It's all about making sure that we are asking the patient or a person with diabetes what works for him or for her, and making sure that we're providing education and support to take that knowledge and put it in action today. I like this quote because it really applies to what we do on a daily basis with people with diabetes. So the difference between school and life. In school, you're taught a lesson and given a test. In life, you're given a test that teaches you a lesson. So think about educating somebody about treatment of hypoglycemia. If that person has never experienced a hypoglycemia and does not really know, like, how is that relevant, we are teaching the patient 15-15 rule. The patient is polite and listening and indicates understanding. But when the actual hypoglycemia happens, will he or she know what to do in response to it? And most of the times they are going to be very reactive and then forget about the 15-15 rule, as it might be too complicated, and drink 20 ounces of orange juice in response. So think about the circumstance of hypoglycemia happening is really a way for a person to learn how to respond to their hypoglycemia. So it's a different need from a person with diabetes. They're responding to a situation of problem solving. They have a problem today that they need to resolve. So that knowledge that they have acquired through our interaction needs to be available to them when they need it. So let's talk about what happens after we provide diabetes self-management education and support. After that, we want to make sure that that knowledge is sustained and can be available to people. Because, as you know, diabetes changes with time. So what if we completed the 10 hours of diabetes education this year, next year their needs might be different, and therefore they would need a different information because they might be now having problems with kidneys or heart problems, or might be empty nesters, or might be transitioning care. So we still want to be able to be available to provide ongoing support for their needs. It could also be a psychosocial challenges that they are contributing to increase blood glucose that needs to be addressed, and their new knowledge and new skills are needed. So to maintain self-care behavior at the level needed to effectively sustain diabetes management over time, people with diabetes benefit from ongoing self-management support. Family members, caregivers, and peers can be effective resource for ongoing support, but often don't know how to help. Therefore, it can be beneficial to include family members and caregivers throughout the DSMES interventions. And we do that a lot, where we invite family members as a support for a diabetes education sessions. And connecting people with diabetes to technology enabled solutions such as mobile apps, digital therapeutics, online programs, and peer groups within the local or online community can encourage practical integration of diabetes self-management and psychosocial support into the existing daily routine between and beyond DSMES sessions. Like right now, I have a patient in his 90s that I have worked with last year, and just recently learned that he is on insulin. And in his 90s, we started him on a continuous blood glucose monitor, and he has indicated that now the technology is his primary support, and continuous glucose is teaching him. The same thing that I was teaching him, now the actual blood glucose and the trends are teaching him. So even in his 90s, he's able to utilize the technology as his support. So now let's talk about interpretive guidelines. We have A, B, C, and D. And the first one is A written curriculum guides evidence-based content and delivery of DSMES services. An evidence-based curriculum with content, learning objective, Method of delivery and criteria for evaluating learning is in place and covers the following 9 topics. So you want to make sure that your curriculum has 9 topics in place, so then you can address it with the patient. So you're prepared to address it. You don't have to address it all if it's not applicable to the patient's need, but your curriculum needs to have the outline of all of those. That includes diabetes pathophysiology, healthy eating, being active, taking medications, monitoring glucose, acute complications that include prevention, detection, and a treatment, including hypo and hyperglycemia, diabetes ketoacidosis, sick day guidelines, and severe weather or situation crisis and diabetes self-management. We also want to have a content related to chronic complications, prevention and detection and treatment, including immunizations and preventive eye, foot, dental care, and renal screening and examinations as indicated per the individual's duration of diabetes and health status. Number 8 is lifestyle and healthy coping, and number 9 is diabetes distress and support. And please note that the problem solving is a person-centered and is addressed within each area when appropriate. So think about problem solving for healthy eating, for being active, taking medication, and that's what we do with diabetes education. We address the patient's needs. What can you do today about your eating? What are you going to be doing differently today about your medication taking compared to the last time I have seen you? So making sure that we really problem solve for each of the 9 content areas. Interpretive guidance B, there is an evidence that the teaching approach is interactive, patient-centered, and incorporates problem solving. The curriculum and other supporting documents are tailored, individualized, and involves interactions and problem solving. And in a few minutes, I'm going to share with you some of the examples of that interaction and patient-centered documentation for this specific indication. Also, the curriculum and or supporting materials are reviewed, revised to ensure they align with current evidence. There is a documentation reflecting at least annual review, revisions of curriculum and or supporting materials by the DSMES team and or by DSMES service stakeholders. What we do in our case, we take the every year we take the diabetes clinical guidelines from American Diabetes Association. We review what's new, what has been revised, and making sure that we are also relating it to our curriculum to make sure that we current with the content and the approaches that we do with our patients. Especially a lot of new evidence is available about technology and then clinical indications. We want to make sure that that our team and then also education team and also our patients are getting top levels evidence-based information every year. And finally, for service outside of the scope of practice of the DSMES team or services, the DSMES team should document communication with referring providers and or other qualified healthcare professionals to support person-centered care. There must be documentation reflecting a procedure for meeting participants' needs when they are outside the scope of practice of a DSMES team or service. So now let's talk about actual examples of the curriculum. First one I would like to start with is the classic, which is the Life with Diabetes. It is a series of teaching outlines from American Diabetes Association. It is a fantastic resource. Even if you're building your own curriculum, this is a resource which you can use to build your individualized curriculum, or you can use this one. It's fantastic because it's very comprehensive and has all that you need to address your patient's needs and also individualize it and document it. We also have many of people using a conversation map, and this is an example of utilizing the 10 hours of DSMES within a 4-week structure education with once a week session, 2 to 3 hours education, and in-person education, and also integrated digital engagement platform that is available in between sessions, and also for people who have completed the education and need support after the 10 hours is completed. This is an example of the learning objectives that are needed for the curriculum to make sure that we indicate within each session, if it's a group session, by the end of a session, participants will be able to, for each session, we need to have a learning objectives. And many of times people ask questions about evaluation. How do we evaluate that people are learning what we are teaching or educating them? And this is an example of evaluation plan for the conversation map for session 1. So knowledge will be evaluated by achievement of learning objectives and by responses to question and participation in activities during the session. The ability to apply the knowledge will be evaluated through the identification of what was personally meaningful at the end of the session, recognition of feelings about diabetes, development of personal action plan to achieve their diabetes care goals, and or the ability to implement the actions identified and throughout the program outcomes measure. So keep in mind that evaluation of a group session versus a one-on-one session, in the end, it's the same thing. We're going to ask the patient, what are you going to be doing differently till the next time I see you? And then build on that, because it means that the patient is agreeing or aligning. The patient determines the actions needed to drive those specific outcomes. This is an example of a curriculum that is taking the patient from the I need help with to I'm working towards it versus yes, I can. And it's using the 7 self-care behaviors of healthy coping, healthy eating, being active, monitoring, taking medications, reducing risk, and problem solving. An example of evaluating patients' confidence in their ability to manage their diabetes, where we ask at the start of care, during, and discharge on a scale of 1 to 5, what is your confidence level in healthy eating or being active, monitoring, and so on. This way, the patient is able to see it, and we are also documenting it in our medical records, where we are able to see the progress that the patient is making with the confidence in his or her ability to manage diabetes. Documentation is very important. It didn't happen if it's not documented. So documentation is crucial in making sure that if there is a different educator who is following with that patient, knows what was done, versus also indicating to a referring provider what we have done with that person with diabetes and next steps. So this is an example of a documentation with the 9 content areas, where we are indicating when we started and a confidence level, and then anything that is applicable to that growing that knowledge and education. What I would like to point to your attention is make sure that the goals that you set are very clear. It's a patient goal. So goals set by the patient, progress to the goals, goal attainment, and support system. Very important that it's a goal that is set by the person with diabetes and not by us. That goal might be, for example, in our case, in home health, a lot of goals are, I don't want to fall anymore. And then the reason that the patient doesn't want to fall anymore is because we're getting a frequent hypoglycemia. So working with with addressing the hypoglycemia, medication management, and all of the other stuff that relates to prevention of the falls, it's a journey, but to the patient, what they don't want to do is fall anymore. And that's a very good goal. They can lower their A1C or improve their glycemic management to get them to that goal of not to fall anymore. But that goal of not falling anymore is something that drives and motivates that person with diabetes to be able to address the 15-15 rule and other things that will get them. So that patient is more likely to learn the information that we are sharing with them because it is related to their big goal and also daily habits and strategies that a person needs to implement to eventually get them to that big goal. That support system is very interesting. Oftentimes I ask the patient at the beginning, not often, but always, who is your support system? And as we work together, that support system often changes. So they identify, they would say, oh, it's my wife or my husband or my doctor is my support system. And as we talk, and then we connect them to the local resources that they're able to attend online communities or other peer support system, they develop a new support system through our education, throughout the DSMES. So what's interesting is that people at the beginning don't know what they don't know. So keep in mind that even the goals that they set at the beginning might change after a first or a second session because they're learning something that they did not know at the beginning. The general approach to individualize the intervention with people with diabetes is to really provide engagement. So it's making sure that people are engaged. Oftentimes, we would, in the old days, we were saying that the patient is not compliant or the patient is not that interested in diabetes. But the fact that a person was coming to the session or is coming to the session, is attending the intervention, is not missing the sessions, that patient is very engaged. And we are in the process of helping the patient to get empowered. And that is a process, it takes time. And that requires empathy, making sure that we are on the patient's side and we are understanding that people with diabetes have to make on average 160 additional decisions every day besides regular life. So it's a lot of work for people with diabetes to manage it all. We want to respect the individual lifestyle, address clinical needs and prioritize on clinical needs, and evaluate personal preferences, assess willingness to change, strategize an ongoing support system, and remember that could change, create interactions that are holistic in health and wellness that generate self-fulfillment in the daily living. So it provides people joy. We don't want people to every day thinking about what they cannot do because they have diabetes. We want them to think about, instead of wasting time on what you cannot do, what you cannot eat, focus on people what you can eat. And that is more empowering. Also, improvement in quality of life, joy, and therefore you're going to improve health outcomes. So patient-centered model, you're very familiar with, but this is a nice summary where we are, in the past, we were focusing on compliance is anticipated, where we kind of assume that we can feed the information, that we're going to educate. The more we educate, the more people would be able to remember and apply. And as you know, knowledge does not equal action. So we really want to create autonomy. We want to get a patient participation, planning with people with diabetes, empower them, have an active participation, have a person to be independent in their decision making, and then really a person with diabetes defines the need with diabetes team. We're not the ones that are defining their needs. It's a person with diabetes who is driving this whole intervention. Stages of change are very practical. We all know about them, but keep in mind, how do we put it in practice? So for example, if you have a person with diabetes with pre-contemplation, that they might not even feel that they have diabetes, or if they do have diabetes, they might not realize that it's a big issue and not a problem. So at that time, you really don't want to do too much education because they're not listening, because there's a lot of feelings and denial in place, but you want to really support those feelings and listen. You want to say, you seem sad, scared, nervous. Provide limited information, but increase awareness of risk. Once you get into contemplation and preparation and action, then you can change the approach. Like with contemplation, you still want to support feelings, but get more on open-ended questions. What will happen if you would consider eating breakfast? What would be the worst thing if you start eating breakfast? Like a simple things for people to start thinking about, weighing the cons and pros of the change. And once you get them in preparation, is also as a stage. You want to provide examples by indicating some people have tried this, instead of necessarily make straight recommendations, but give them examples of the different options, option 1, 2, and 3, that other people got, and then it worked for them. Once you get into action, that's obvious. You can that's an easy state, because then we can provide specific strategies that people put in place. Maintenance and relapse, keep in mind that we establish habits, we're great for it, but habits are not necessarily going to stay for a very long time. So we want to really make sure that we normalize the fact that it's okay to relapse. And if you relapse, come back to diabetes self-management, education, and support, and we will help. When it comes to group education, keep in mind that we still can individualize our education in a group setup. And actually, group can work to our advantage, because people in a group can support each other. But there is a logic, or maybe a system or process in place, the way that group supports each other and works to the best. And this is an example of the group development model, where people want to first form. So you don't want to be jumping in just immediately educating them on diabetes, but allowing them to introduce themselves, so they can get to know who they are as human beings, not necessarily as diabetes people, but as people. Once they learn about themselves, and they can start saying, it's so difficult, but it's difficult for all of us. So let's now normalize it. Let's do something about it. And then people can start performing. And many times people think that it takes a long time once people start talking about their diabetes, but that's not the case. Allowing people to talk about themselves and their diabetes, it's a great investment, because once they are able to verbalize what's going on, then they're ready to learn what they can do about it. So all of us are much more than educators. You can see that we are more of a coaches. We help people. We still need to educate because we're clinicians, and diabetes self-management education is a serious business of providing intervention with 7 self-care behaviors to make sure that people know what to eat, how to eat it, physical activity, medication taking, and coping. So there is a lot of education happening, but think about how we provide that education. That's another skill set. So in summary, coaching helps a person with diabetes change in the way they wish, and helping them go in the direction they want to go. Also, coaching builds awareness, empowers choice, and leads to change. And finally, supports a person with diabetes at every level in becoming who he or she wants to be. So now let's reflect on what we have done, and just 2 testing your knowledge questions. Effective curriculum should always include questions and answers, learning objectives, content, methods of delivery, and methods of evaluation, videos, or present time for breaks. The answer is learning objectives, content, methods of delivery, and methods of evaluation. And this is what we just discussed and provided you with the samples of it. The second question is the education plan, the education plan should be tailored to fit the needs of each individual participant, should always include all 9 content areas regardless of participant's age, should never be altered as diabetes is the same as it was 75 years ago, or should focus on nutrition and medication if the patient has limited ability to concentrate. And the answer is A, should be tailored to fit the needs of each individual participant. It's not enough to have a sheet and indicate, I have educated the patient about A1C, I have educated the patient about blood glucose, healthy eating, coping, medication taking, and so on. We really need to make sure that we put in the simple words in action. So instead of wasting your time indicating, that you have educated the patient on all of those things, be simple and put it in. The patient is willing to eat breakfast. The patient is gonna talk to the physician about sulfonylureas because the sulfonylureas might be contributing to hypoglycemia. So make it very specific to the actual action that the person is working on. This way, that specific action is the one that you follow up and build on. When the person is able to do that one action, the positive action creates another positive action, another action, and the patient feels empowered, great about himself, and is able to build additional healthy actions. When we have general information, the people don't own it. It doesn't belong to them. They are not able to internalize it, and it's just the information, not an action. To conclude, I would like to thank you for your time and our discussion on Standard 4, which stands for Delivery and Design of DSMES Services. And I would love for you to enjoy the journey of outcome-driven and engaging interaction with people with diabetes that delivers your DSMES curriculum. I am very excited about Standard 4 because I think Standard 4 is really the core of what we do, because it allows us to have a very productive interaction with our people with diabetes, and then really driving that outcome. So the Standard 4, in my opinion, is the core of the whole DSMES. And I will also welcome you to stay tuned for another idea example from another quality coordinator discussing other curriculum options to give you more examples and strategies for you to apply in your own practice. Thank you for your time today and have an amazing day. Bye-bye.